thought that we would share with you our challenging of taking care of patients with myocardial infarction during the pandemic. The structure of this presentation, which was prepared and will be presented by our IC fellows, some of them are coming to the second year, some of them are leaving us by the end of this calendar year. So they prepared some case presentations, a review of the worldwide experience, guidelines, and also a glimpse of what's happening in our center here at MedStar. So without further ado, I'd like to ask to start with maybe the case presentations, and the first one will be presented by, I believe, you, Feng.
No, I'll present
Khalid, yeah, sorry.
All right, so the first patient is a 48-year-old man, history of diabetes, pre-diabetes, obesity, sleep apnea on CPAP. He developed progressive chest pain while playing video games at home. A week before, he had a viral prodrome with symptoms of fever, chills, myalgias, and shortness of breath. He went to an urgent care facility where he was treated with ibuprofen and steroid taper, and his symptoms improved. He recalls having one sick contact with similar symptoms. Next slide. So with onset of chest pain this time, he went to an outside hospital first where workup showed elevated troponins, so he was transferred to our facility. Here at admission, his vital signs were normal. He was afebrile. On physical exam, only pertinent finding was jugular venous distension. His chest X-ray was normal. ECG is displayed at the next slide. So it showed sinus rhythm and occasional PVCs. There are Q waves in the inferior leads, and in the V1, V2, R wave is taller, so possible old inferior posterior infarct, but no ST segment elevation. His labs showed an initial troponin was significantly elevated at 116, and that peaked at 196. So he was initially treated medically with a loading dose of dual antiplatelet therapy, aspirin and clopidogrel, and IV heparin was also initiated. Other labs showed elevated inflammatory markers, including WBC, platelet count, sedimentation rate, CRP, ferritin, and D-dimers. And his nasopharyngeal swab was positive for COVID-19 reverse transcriptase PCR assay. So he was continued on medical therapy. He remained chest pain free. So there was no urgency to angiography. So it was done on day 4. So we'll look at the images. So in this view, you can see there's intermediate disease in the proximal OM1 and mid LAD, but nothing occlusive, no focal filling defects. Another view showing focusing more on the LAD, and the mid LAD disease is visible. Again, not a critical lesion. RCA was also free of disease. There was somewhat sluggish flow. However, there was no high-grade lesion. His LVEDP was 45. So the sluggish flow could be explained by the elevated filling pressures or microvascular obstruction. His EF was on transthoracic echo was 45%. There was mild hypokinesis of the inferior and inferior lateral walls. So he was treated with aggressive diuresis and discharged on day 7 on guideline-directed medical therapy with DAPT, beta blockers, ACE inhibitors, and statin therapy. So summary, this patient was young. He had conventional risk factors for CAD, presented with non-ST segment elevation myocardial infarction, Angiography showed non-obstructive CAD. In this patient, potential mechanisms for injury may include an acute infection triggering an intense demand-supply mismatch and ischemia and then infarction. And further related to that is initiation of a cytokine storm, which precipitated plaque rupture. And the key decision was timing of angiography. Since this patient had non-Stemi, and he was pain-free after his admission, and he was doing fine on medical therapy. So we decided to wait until every test was available. So in patients with NSTEMI without ongoing angina, signs of ischemia or hemodynamic instability, and suspected COVID-19, it is reasonable to first pursue medical therapy pending the results rather than immediate cardiac catheterization while balancing the risks of healthcare exposure. So case 2 will be presented by Yufeng.
So the second case is a 65-year-old African American female with history of hypertension, diabetes, left breast cancer in June 2018. State has post-death lumpectomy, radiation, and immune therapy. Prior alcohol and cocaine uses. She presented to ER on the April 23rd for left side chest pain, was sharp, constant, and with some radiation to left arm, associated with the shortness of breath, cough, and fever. And she had a prior contact with the COVID-19 patient. And it was hypertensive. Blood pressure was 78 over 58 millimeter of mercury, heart rate 86, respiration rate 25, temperature 96.8. O2 star was 94. Otherwise, physical exam was unremarkable. Was 88.7 and trending up 100. Other labs include airway white count, which neutrophil 89.5% and lymphocytes 4.5. HNH was stable. Platelet 150. Thyroid was 68. GRP 100. Ferritin is 1,098. D-dimer was elevated at 0.79. And BUN creatinine is 87 over 3.5. Sodium 120. Potassium 6.4. Lactic acid was 2.3. And the nasopharyngeal swab was also positive for COVID-19 RNA. Her previous in November showed the normal left and right heart function sites. Next. So this is her EKG on presentation. Showed in lateral some ST elevation with some ST depression, and we want to be 3. Next. Bilateral lung opacities. Cohort was called, so we brought a patient to the cath lab, and this is the image. Play it again. So film, we did not see significant disease on the subsystem, but it's an intermediate lesion on the proximal. RCA is also some disease, nothing. So the AV gram was. So the interlateral apical, almost the basal anterior and basal inferior has significant reduced contractility. Yeah, it's about 30-35%. So right heart cath was also performed, which revealed moderate post-capillary pulmonary hypertension, R pressure of 19, RV is 48/18, PA is 50/24, which is a mean PA of 36, weight was 39, and cardiac output was lower side, cardiac index 2. So no intervention was performed, and IABP was placed for hemodynamic support, and she was to ICU. So while she was in ICU, Ventimax at 6 liter and setting at 94, she was awake another 1 times 3 and answer questions appropriately. Thanks. Her condition deteriorated rapidly. She was getting hypoxic with increased shortness of breath, so she was intubated midnight around 7 p.m. She developed she had this acute renal failure with severe metabolic acidosis, including DKA and lactic acidosis. Her blood glucose went up to 600 and lactic acid went up to 13. So she was placed on the CRT, and she was in cardiogenic shock and eventually required 3 vasopressors and 2 inotropes. She did not respond well to the treatments, and her cause status was changed to CMO by family. So she passed away after extubation and removal of support. So in summary, this patient has conventional factors for coronary artery disease, present with a Stemi, but angiographically, line of suspicion was noted, and LV-gram showed LV dysfunction. So the potential mechanism for the LV dysfunction could be COVID-19 myocarditis or stress cardiomyopathy.
Yeah, so I think maybe we can take maybe 5 minutes to discussion about the 2 cases. There is a big difference. The second patient was taken immediately to the cath lab, even though she was a high suspicious for COVID-19. She had all the clinical, and even before the testing, it seems to be high probability of COVID-19. But because the EKG was very remarkable of ST elevation, after a discussion, we decided to take her immediately to the cath lab. The first patient, when he was presented initially from an outlying hospital, there was some 1 millimeter ST elevation on the lateral leads, but by the time he came to the hospital center, his pain has been subsided, and he was again low probability initially to COVID-19, turned to be positive by the testing, and later on there was a question whether he needs to be cath or not. At the time that he's still positive for COVID-19, the decision again was to cath him, and I think what's commonality in both of those cases that they did not have an obstructive disease. So Brian, you can take it from now.
Thank you, Dr. Waxman, for that, and Yufeng and Nauman for their presentations. So this goes without saying, we're all feeling the impact of the COVID-19 pandemic as numbers continue to increase here in the US and worldwide. It's having an enormous impact on our healthcare systems, especially in hospitals and hotspots such as here in Washington, D.C. Hospitals have canceled elective procedures, converted outpatient visits to telemedicine, and limited visitors to the hospital, all to help stop the spread of the infection and allocate resources to treating COVID-19 patients. So during this pandemic crisis, the management of acute myocardial infarction could be challenging. Us as providers need to balance the risk of exposing personnel and patients to the infection versus the known primary benefit of primary PCI. So when we talk about the treatment of Stemi, it's important to think about the treatment of Stemi as a system-wide management. Patient who presents with a Stemi is going to come across multiple different levels of care. The EMS personnel will see the patient on the field. They'll get triaged in the emergency department by physicians and nurses, then brought out to the cath lab where they're seen by the cath lab team and then treated by the interventional cardiologist. And after revascularization, these patients are brought to the cardiac intensive care unit for post-PCI care, and then ultimately the general cardiology floor before their discharge. And us as a center have gotten extremely efficient at getting people through the system to get treated for their STEMI. And hence the door to balloon time was created with the goal of getting the coronary blood vessel open within 90 minutes. And this is important because the quicker we can get the patient to the cath lab and the vessel open, mortality rate improves. Unfortunately, during a pandemic such as the COVID-19 pandemic, every link within this system is going to be affected. So the first thing to discuss is overall STEMI volume. What we're seeing is there is a delay from symptom onset to first medical contact. So patients are fearful about seeking medical attention for cardiac symptoms during this pandemic, as they are concerned about acquiring the infection if they come into the hospital to get evaluated. And this has been shown in a few studies so far. This study was recently published in JACC. What they did here was they took 9 high-volume PCI centers across the U.S. You can see here on the upper left, the East Coast, the Midwest, and the West Coast. And they looked at their these 9 centers' STEMI volumes pre and during COVID. If you see to the right in this graph, the blue bars are the months prior to the COVID pandemic. You can see overall, relatively, the STEMI volume was fairly consistent in these 9 total centers. But then as we approached 2020, and specifically February into March, you see a dramatic decline in the STEMI volume at these 9 centers. They quoted a decline of about 38%. And this has actually been replicated in other studies in Europe, specifically Spain. If you look in the middle here, there was a 40% decline in the number of cath lab activations for STEMIs during the COVID era, which is the gray bar, versus prior to that. And just last week, the NHS in the UK published some preliminary data discussing their experience during COVID. And what this graph represents is just the daily number of emergency department visits from cardiac patients. Again, you can see that prior to 2020, it was fairly consistent. And then as we approach February and then certainly March into April, there's been a dramatic decline in the amount of visits in the ER in England, cardiac patients. So this is obviously very concerning. Patients are still having MIs, but they are not seeking medical attention. They're either just dying at home without being evaluated by a provider, or we're seeing patients present very late in their presentations with subsequent complications such as cardiogenic shock, or even post-MI mechanical complications like VSD or PAP muscle rupture. So there's actually been an initiative from the ACC to try to get the word out to the community, just advising patients who have known cardiac conditions or those who are having symptoms of a heart attack or a stroke to seek medical conditions evaluation even during this current pandemic. So these have been rolled out over the last few weeks. And then what we also know is once patients are arriving to the hospital, there is evidence that there is a delay from true STEMI patients getting evaluated and treated in the cath lab. And this makes sense as there's infection control measures that have been employed at every level of care in the EMS, the ER, and the cath lab to make sure that patients are being rapidly tested and proper PPE has been worn to help prevent the spread of the infection to other hospital staff and patients. This one study from China kind of just outlines what we're talking about. This is a high volume PCI center in Hong Kong, China. And they demonstrate that since late January, so during the COVID pandemic, every step along the way, there's been a delay in care, symptom onset to first medical contact, door to device, and cath lab arrival to device as well. So even if you have a well-built system to care for STEMI patients, this could easily be disrupted during the pandemic. And this is obviously important as any delay in treatment increases mortality in STEMI patients. So really the concept of time is muscle should be still remembered during these tough times. And then the other thing to note, which has been seen, is not all COVID-19 STEMIs are true STEMIs, as we saw in the second case presented by Yufeng. This case series was recently published in New England Journal of Medicine by providers in New York City. And what they showed is a series of 18 patients with COVID-19 infection who developed ST elevation MI on an EKG. And they found that not all of them were due to true obstructive coronary disease. They estimated that 8 of the 18 patients were having STEMIs due to obstructive coronary disease, while the other 10 were due to other causes. And what we're seeing is a higher evidence of myocarditis and also stress-induced cardiomyopathy. And what they also found was of these 18 patients, 9 actually underwent coronary angiography, and only 6 of those patients actually were found to have obstructive disease. And then the other thing to note is it's a very sick population. Of these 18 patients who presented with COVID-19 and also STEMI, 13 of them died in the hospital. So a mortality rate of about 75%. So initially, there was a lot of discussion about using lytics as kind of the first line treatment for COVID-19 patients with evidence of a STEMI. The thought was it could be administered quickly and without exposing a lot of hospital staff. And there was initial evidence presented from China about the benefits of doing a lytic therapy. This is just a snapshot from one study in China with their algorithm, which was a bit convoluted, but essentially what they recommended was on the left, for any patient with COVID-19 presenting with a STEMI and had symptoms of less than 12 hours, they recommended giving lytics as the initial strategy in isolated ward and only pursuing PCI after the patient overcame their COVID-19 pneumonia or if there was a discussion with the providers at the hospital. And then SCAI and the Canadian Association of Interventional Cardiology published their first set of guidelines about treating STEMI during the COVID-19 pandemic. And then their first set of guidelines, they actually did recommend the use of lytics. As you can see here, this is the algorithm from SCAI about the treatment of STEMI in COVID-19 patients. Once again, it's a bit convoluted, but what you can see is they essentially broke it down into 2 risk stratifications, high-risk patients and low-risk patients. They define high-risk patients as those patients with an anterior located MI, hypotension, cardiogenic shock, or life-threatening arrhythmias. They said for those patients, consider primary PCI. But then for low-risk patients, which they defined as either inferior STEMI or lateral STEMI, you could consider lytics as the initial therapy. And then this was also seen in the Canadian Association of Interventional Cardiology. So the first set of guidelines all believe that a lytic strategy could be a reasonable strategy for treating these patients. However, there are certainly a lot of risks that come with treating STEMI patients with lytics, especially in this COVID-19 patient population. These patients are going to have a lot of contraindications to receive thrombolysis. They may have a previous history of a stroke. A lot of these tend to be elderly patients, and a lot of these patients may have active bleeding or thrombocytopenia. As we know, there's a direct correlation between COVID-19 infection and DIC. And also a lot of these patients due to the cytokine storm in COVID-19 are presenting in multi-organ failure with liver and kidney damage, making lytics a relative contraindication. Furthermore, we know that about a third of patients who are symptomatic from COVID-19 can go into ARDS, thus giving lytics will increase the risk of alveolar hemorrhage. And then, as we discussed before, not all patients with COVID-19 presenting with a Stemi are going to have acute coronary syndrome due to obstructive coronary disease. They might have what's called acute coronary mimic, like we talked about before, Takotsubo, or myopericarditis, spontaneous coronary artery dissection. Thus, giving lytics will have no real benefit in these patient groups. And then finally, what we know from the pre-COVID era, patients who are receiving lytics have a use of increased hospital resources. They tend to have longer length of stays in the hospital, longer stays in the ICU as compared to PCI, and thus putting more of a strain on the hospital during these tough times, and also using up ICU beds, which can be allocated towards treating more COVID-19 patients. So though the initial thought of using lytics was attractive as it provided less exposure to the staff, there really is a lot of risks that come with treating STEMI patients with lytics, as we discussed. Now, really, the guidelines across are recommending that still to consider primary PCI for STEMI patients. So this is the updated SCI guidelines for the treatment of STEMI, which was just recently published. And it's a lot more straightforward and a lot easier to read. And what you can see is on the left, if you have a patient with intermediate to low probability of COVID-19 in the STEMI, you should proceed with primary PCI. And then the new addition was here on the left for patients with either COVID-19 or probable COVID-19 based on inflammatory markers or symptoms, and they have symptoms consistent for an MI with an EKG consistent with an MI. They recommend considering using a point of care ultrasound to evaluate for any wall motion abnormalities, which would be consistent with a specific coronary distribution. If that is seen, then the patient should proceed with a primary PCI. Otherwise, they recommend not primary PCI and for further workup to consider other etiologies for the cause for the ST elevation MI. All the guidelines in addition are recommending that in the cath lab that all cath lab personnel wear proper PPE and are aware on how to put on the PPE and also take off the PPE, which Tron will talk about in a little bit more detail. And then also to have one cath lab room dedicated to treating COVID-19 patients. We have done that here at our institution. We have designated Lab 8 as our COVID-19 lab. So any patient where we're concerned that they may have COVID-19, they're going to that lab where they're treated and then cleaned afterwards. So in conclusion, for the management of STEMI, the treatment of STEMI patients during a pandemic can be challenging. While lytics can be a potentially good choice, many patients have contraindications, and if they're treated with the lytics, they could end up using more resources in the hospital setting. Also, with a high probability of the coronary angiogram showing normal coronary arteries during the acute infection, primary PCI with coronary angiogram is the initial preferred strategy in guidelines at this time. Non-invasive diagnostic testing is useful to differentiate true STEMIs from conditions mimicking STEMIs. In addition, training of the cath lab personnel on how to use PPE is crucial to limit the risk of acquiring the infection. And then finally, a dedicated cath lab for possible COVID-19 patients is needed as well. And then just quickly for NSTEMI, luckily this is a little bit straightforward, as we saw in the first case presented by Nauman. What we know is a significant portion of patients with COVID-19 have evidence of elevated biomarkers, and patients who have elevation of troponins have a poor prognosis as compared to COVID-19 patients who do not have elevated troponin. The challenge for us is to figure out what the etiology of the elevation of troponin is. Is it due to a true plaque rupture, or is it caused by some other non-coronary obstructive etiology, such as myocarditis, stress cardiomyopathy, etc.? Or is it just a type 2 MI in the setting of the severe illness that we're seeing with these COVID-19 patients in their cytokine storm and hypoxemia? The management, however, is pretty straightforward. This is our strategy that we propose and is also in the guidelines as well. For high-risk Stemi patients, so those are patients with a high GRACE score or hemodynamically with instability, the recommendation is primary PCI. Other patients who are low risk or have just unstable angina, the current recommendation is just medical treatment for stabilization with follow-up once they have overcome the infection. And this is just a snapshot of the algorithm from SKY. And you can see, again, they divide from high risk to not very high risk. And they define high risk Stemi as refractory chest pain, hypotension, heart failure, shock, or life-threatening arrhythmia. And then a similar pattern is seen with the Canadian Association of Interventional Cardiology. So now Sharon's going to present just our proposed management for ACS during the COVID-19 pandemic.
Thank you, Brian. So we actually proposed a document when SKY and Canadian Association of Interventional Cardiology initially proposed their guidelines. So if we go to the next slide. So the most important part of managing these patients is for any facility, the facility needs to be COVID-19 trained. That is, all the personnel involved in PCI before the patient getting transferred to the cath lab, and even in the cath lab, all the personnel should know what are the steps of donning and doffing. So we outlined in our position paper all the 6 steps of the donning and doffing. So these are the steps that need to be followed before the procedure and few of the steps after the procedure. And this is in line with all the previous recommendations. And if you go to the next slide. So in the first SKY guidelines and the Canadian Association of Interventional Cardiology guidelines, they recommended lytics in low-risk patients. And we did not agree with that. And we submitted our proposal to JACC Interventions, which is currently under review. This particular guideline is almost similar to the most recent SKY updated version, which was just published last week. So in any patient who basically presents with Stemi, you have to do a rapid COVID-19 test. And if it is negative, you can go ahead and do standard treatment as per the guidelines. But if it's a COVID-19 positive, or even though it is negative with a high pretest probability, we actually recommend a point of care ultrasound instead of standard transthoracic echocardiogram. And if there is a new wall motion abnormality, then proceed with management as Stemi. But if there is global dysfunction or wall motion abnormality not correlating with EKG, then there is a high probability of myocarditis, and we just need to be careful before transferring the patient to the cath lab. And in our proposal document, we also gave some guidelines for the community. So in the community, the most important thing is having a lab where all the personnel are trained to deal with COVID-19 patients. And even the hospital should be trained to deal with sick COVID-19 patients. So the first and foremost important criteria is to designate a facility as a PCI COVID-19 trained lab. So if a patient presents with Stemi who is under investigation or positive and with a symptom onset of less than 12 hours, if it is a PCI COVID-19 trained lab, we have to go ahead with the PCI. But if it is not a PCI trained lab, COVID-19 trained lab, and if the transfer is greater than 120 minutes, then in only those scenarios, we have to consider thrombolytics But the most important part, even for thrombolytic consideration, is to rule out all acute coronary syndrome
To prevent further spread, we are following
doing
the guidance of the U.S. Centers for Disease Control and Prevention.
or maybe looking at the EKG or chest X-ray. And if the symptom onset is greater than 12 hours, the treatment is actually based on clinical status. Only if there is hemodynamic or clinical instability, those patients need to be transferred to the PCI.
We have also initiated a temporary visitor policy at all MedStar Health locations.
Go to the next slide.
As the COVID-19 status continues to rapidly evolve, visitor restrictions
This was our proposal. This is currently under review, and Dr. Case is going to review our experience on acute myocardial infarction.
In specific circumstances, no visitors are permitted in our cancer infusion locations due to increased risk to immunocompromised.
Can somebody mute their line, please?
I think call in user 13.
So just briefly to have two slides just about our current experience during the COVID. Unlike what I presented from those few studies, our numbers overall have not dramatically decreased. January was a busy month for us, but overall, our numbers have been constant between February, March, and April. So the left is just code heart activations, and then on the right are true STEMI cases that received a PCI. If you went back past January into 2019, we typically range between 10 to 15 cases a month. So this really doesn't go too far off. And then despite all the limitations with getting a patient through the system, our door to balloon time to date has still remained less than 90 minutes, even during all the constraints with the pandemic. That's all I have for that.
Thank you, Brian, Sharon, Yufeng, and Khalid. So I think the best thing would be to open this presentation to questions. I would mention maybe one thing that we're basically treating now almost every STEMI like potentially COVID-19, again, to save time. The team is pretty much, when it's coming on a STEMI, on EKG and clinically, the team is very experienced in terms of using the PPE. We're doing all the procedures in Lab 8, and it just helps us basically to take one approach to all the patients. But as you saw, not all our patients are COVID-19. We have real STEMIs. They're still coming along, and they're being treated. So it's just hard to vet patients out based on the test, and the test takes time. I mean, it used to be hours. Now maybe it's into the minutes, but it's still, we don't want to delay, so we want to keep the door to balloon time. And that helps to all the other patients who are COVID negative, and they still come with real STEMI. One other thing is that, in my opinion, the lytics should be really remain a last resort. It's something that we don't like to put the contraindication on an approved drug, but at this moment, we should really try to avoid using analytics, which used to be the recommendation early on. And thirdly, the anticoagulation. So again, there is a lot of thrombosis, and there was a lot talking about which way those patients should be treated in terms of anticoagulation. If this is a real STEMI and we don't have any information, the patient is COVID-19 and is not behaving with any thrombosis, we should not do any different than what we're doing on the real treatment of the STEMI patients, because by adding all kind of anticoagulants, we can just increase the bleeding rate. And remember, most of our patients are still not COVID-19. They are real STEMIs, and they should be treated the way that we treat before and not to overreact, even if you see a clot in the coronary artery, because that doesn't mean that he's a COVID-19. I think that giving the information about the COVID-19 testing for the non-STEMI patients helps us a lot to determine whether this patient should come fairly quickly to the lab or not. I think the patient that we presented early on was a good example of someone who could have waited. He actually was cleared by the ID team to have the cardiac catheterization a few days after the patient was presented, and the clinical situation allowed it. So there's still a gray zone about patients that we don't know, and again, since our team is very trained, we have a dedicated lab, we rather taking those patients right now more frequently to the cath lab rather than to miss some real STEMIs. So I'll keep it here, and we have a few minutes for discussion, and just either chat with us or unmute and tell us what you have in mind.
Ron? Yeah, this is Stu Sides. Can you hear me?
Yes, I hear you very well. Thanks.
Thank you very much. My thanks to the guys who presented. It was very clear and very, very well done. So thank you. I simply wanted to reemphasize my own thinking, or reemphasize what you've said, which is, those of us who lived through an era when we did use a lot of lytics, it's important to remember that lytics at best had a 60 or 70% efficacy rate in recanalization. You probably have more accurate data than I do, but there certainly were a significant number of patients who did not reperfuse given thrombolytics. Moreover, there is a significant incidence of intracerebral hemorrhage, which almost always is a clinical disaster. And so when one sort of looks at the balance, at least from the patient's standpoint, putting aside for a moment the importance of protecting our provider teams, the idea, frankly, of getting a thrombolytic, particularly in the setting of a big myocardial infarction that may do a lot of damage, is a very, very appealing prospect. And then if you say, well, what about people who don't have big myocardial infarctions, who have a small infarct, to some extent you could almost say that it's better to ride it out than give a thrombolytic. If you're reluctant to take the patient to the cath lab and they have a small wall motion abnormality and have a small lateral MI, if it were me or my patient, I would seriously balance medical treatment against the use of thrombolytics. Thrombolytics, I think, have such significant hazards, not to mention all the things that have been brought up. So thank you very much for the talk. It was terrific. I'm glad that we are creating our own guidelines. And again, as Ron said, I'd be very, very cautious and reserved with the use of thrombolytics.
Thank you, Stu. Are there any other comments or questions? I would mention maybe one thing that we have a lot of manifestations of cardiac. We had one patient that we opted not to present because it was not a STEMI, but she presented with the cardiac tamponade. And again, what we need to be very careful in terms of vetting the EKGs. The EKGs looks like ST elevation, but they are not that typical. It's not the classical, so there is some suspicious with the EKG. But again, we can miss STEMIs by, especially for circumflex and diagonals, if we're just looking just on EKGs. So if you're not sure, it's better to catch those patients early on. Again, we are trained, and we, with a really dedicated team in the cath lab with all the PPE, and everybody take care of themselves. I think the team is pretty much now trained to take almost every patient in suspicious. And as we look at all those EKGs and echoes, we learn to sometimes determine who would be and who would not be a real STEMI. But until we know that for sure, it's better to cut them rather than to miss a real STEMI that has probably not even may have a COVID-19.
Ron, this is Steve Epstein. Could you expand a little bit on the availability and the time it takes to test someone for COVID-19? I mean, is that a really rapid test now? You indicated that it was variable. How, from the time you're wondering whether the patient has COVID-19 until the time you get the result, how long is that?
Yeah, I believe, again, this may be changing because when we started, it was 3 days at the very beginning testing. I think then it went to the 90 minutes. I'm not sure that we do have, to the best of my knowledge, we don't have the 10 minutes or the 5 minutes test yet available. But if someone knows that it is available, you should correct me on that one. So I would say that 90 minutes, in my opinion, is the earliest that we have right now. So you understand, Steve, it's not going to help us if you have the 10-minute. And even if they have, the patient does have it, it doesn't mean that he should definitely rule out as a STEMI. So I think that it's pretty safe right now. If you take all the measurements and you have a dedicated room, the problem is going to start when we're starting to see more elective patients. They don't want to mingle with patients with COVID-19, and they want to have safe environment. And I think that's upon us, once we start to do the elective cases, to create those safe environment, because that's the first question that patients come to us. If they are planned or scheduling for elective cases, would I get a COVID-free environment? And that's something that our team, all the way from the leadership to the Cath Lab management, Dion and Lowell, are working on right now.
Yeah, that's a great point. That's a great point.
You know, I think the other thing is from the standpoint of how we, this is Stu again, I treat our patients. You know, COVID is a highly transmissible disease with an extraordinarily variable clinical course. But for any individual patient, it may or may not be the most important healthcare issue in their portfolio. I would say, particularly for a younger person coming in with a STEMI, the STEMI is a much more important part of their sort of healthcare picture than the fact that they may be culture positive or in the future antibody positive for COVID-19. And I think, you know, what we're seeing is a maturation, I think, of our clinical approach as we learn more and more about the disease and understand that the denominator of COVID infection may be much larger than was initially appreciated for obvious reasons. And so, again, I think it's important that we not overly distort our care pathways simply because of the presence of COVID infection. Ron is quite right. I mean, part of what we're working on right now is as we progressively, quote unquote, reopen to less obviously emergent cases, how to reassure the public, because remember, the pipeline for elective cases has to start with patients who present themselves either to us or to their referring physicians, and then referring physicians who themselves are available to see those patients and refer them, and so forth and so on. And again, COVID has taken over, or has been developed in an outsized way in the mind of the individual patient. We've got to create an environment and reassurance that allows them to come into our four walls. Thanks.
And nationwide, what seems to be established is that the patients who are scheduled for elective procedure come to the clinic that is assigned by the hospital or to the hospital, having the test and coming for the procedure 3 days later. So that is the time that everybody can get a test. Obviously, some do have the rapid test, but the rapid test is not available everywhere. And I think from the safety perspective, that 3 days interval or 2 days interval, if you have a test and you deem to be negative, that would give some assurance that we are not bringing a lot of patients for elective procedure who are basically infected. So that seems to be what's going to happen here. I know that in neighboring hospitals in neighboring states, that's what they're doing, but that's pretty much what I hear from everyone that we discuss the patients, and that's probably going to be true for TAVR patients and for Watchman patients, and for every elective patients, they would have to be cleared by the testing, and probably also the medical personnel at some point will have to be tested just to make sure that we are providing a COVID-19 free environment to continue our loading work. Okay, so if there is no other comments, I'd like to thank you for participating and being with us. And if you have any other questions, don't hesitate to contact us by email. Also, if you want to hear what's happening in the country and worldwide, I would encourage you to go to CRT Online. There is a series of interviews that I did from people from Milan, from Rotterdam, from different areas, New York, how they deal with that and different aspects. And this series is going to continue with the participation also of FDA and others. So it's free. It's on crtonline.org, and we're going to put that grand rounds also for those who missed it. Thank you very much, and thanks Sharon and Brian and Yufeng and Numan for participating and preparing this presentation.